Okay.
So we have an 80-year-old female with blurred vision in both eyes and worse in the left. She has history of a stroke in early 2023, history of hypercholesterolemia, hypertension. She's received her influenza vaccine and other vaccines, history of a heart valve and a heart stent, well, 3 heart stents. Her meds are atenolol, statins, methotrexate, clopidogrel, Otezla, on aspirin and a few other vitamins, and losartan as well. So her vision has worsened to 20/50 in both eyes, and pressure is within normal limits.
Am I allowed to ask what she takes the methotrexate for? Is it like a rheumatologic?
She's taking some roommate. Yeah, I think it's rheumatology.
Just curious.
Yeah, I'm not sure.
If it involves
Yeah, she's probably.
anything related to this state.
Years old.
Just curious, because I'm on the uveitis clinic. Okay.
Okay, the arrow should. Does it work? Hold on. Just like that. Hold on. Right. Okay, now do it. There you go.
Oh, yeah, do we know that?
What happened? What did you
Is this acute blurry vision or
Chronic.
chronic?
Yeah.
Okay. So this is a color photos of the right eye. The nerve looks, it's a pink sharp flat, but with some PPA surrounding it. The vessels look a little bit tortuous. It looks like a little bit of AV necking, severely and inferior arcade. Attention is drawn to the macula. There's a yellow kind of pigment in a circular pattern right over the fovea.
What's good description, like round description right in the center?
In the left eye color from this photo, so overall pretty similar. Maybe the lesion is just a little bit larger in terms of that yellow macular lesion
And yeah, she was complaining of a slight worse vision
in that left eye.
There's some really symmetric shadows.
Oh, so I think an artifact, like if you go between these two, maybe
Yeah,
like at the
yeah.
bottom in there.
Yeah, it might be artifact. The other thing on the color picture, outside of that, do you see any other spots? Like up here and there?
Do I see any spots? Like little, like hypo, kind of
There's little spots.
hypo, reflective spots, maybe?
Yeah. Do you have your?
Hypopigmented spots. Oh,
Your
right,
arrow?
there it is.
Yeah.
Let's see, can you go back one? Or forward one? These little spots?
Yeah.
Oh, okay, now I see them.
It's one of those things you can
Okay. Good. Those might show up on the other images too.
Okay, so we have an infrared photo of the right eye. So their attention is drawn centrally. There are areas of hypo and hyper. Infrared, is it reflectance?
Yeah,
Reflectance in the macula corresponding to that kind of yellowish lesion. There are kind of speckled areas of hyper again and hypo reflectance kind of throughout the posterior pole, which are probably those hypopigmented spots. Like,
Can you point to some of the other
yes,
spots?
these ones like kind of up here,
Right.
kind of throughout.
There's a lot of them, aren't there?
There are a lot of them. Yeah.
So what's their diameter about?
So if you compare it to like the vein coming out of the optic nerve, so that would be like 125 microns. So those little spots are maybe a half, maybe a third.
Like
So
50 microns. So yeah, I'd say, so like there's 50 micron hypo-reflective spots. There's probably, I don't know, 50 or 100 of them scattered in the superior and inferior, something like that.
So the left eye is overall pretty similar, just that central lesion is a little larger, but again, the hypo and hyper reflective spots. More so kind of centrally, and then kind of dispersed throughout those hypo reflective spots, again, like that 50 microns. And for this, it looks like a little bit less in the tier 3. I'm not sure if you agree, but it'd be like 15 on the side.
Gives me like a real tight one. I would say there were fewer, not less.
Okay, fewer.
It's like a grammar police.
Yes, fewer. Okay, so now we have an auto fluorescence. So we have so centrally in the macula, an area of hypoautofluorescence surrounded, or I should say somewhat hyperautofluorescence surrounded by hypoautofluorescence. And then towards the nerve, some areas of hyper and hypoautofluorescence, and then those little 50 micron areas of hypoautofluorescence. And then same for the left eye overall.
I was saying nerve looks really interesting, but I don't think it's really much part of the case, but someday I have to think about that more.
Yeah.
Nerve cover, it does.
Does a PPA nerve look like that at all?
I gotta start looking at it more. That one's kind of striking.
It looks like there's some drusen.
Yeah, there's a lot of pigment. There's
Yeah.
gotta be lipofuscin or something, maybe. Yeah, I don't know if they're dystrophy. They're not on the disc. Yeah, they're funny looking.
And we got some slices through it.
Okay, so this is an OCT, it looks like of the right eye. Attention is drawn, subfoveally, there's a large, it looks like sub, RPE, no. Yeah, sub RPE, kind of like dome shaped, like hypo and hyper reflective lesion. It looks like just above that, the RPE is, or has some abnormalities, maybe more kind of nasally towards the nerve, some kind of hyperreflective foci, kind of just superior to that. And then towards the nerve, some more hyperreflective foci.
It's tricky to tell which layer this is. So this is a hard one, but if you look at them here, like look here,
Mhm.
can you tell there's 4 layers, 4 bands you can see.
Uh-huh.
Do you know what's this bottom one?
So that one should be, Brooks membrane, and then RPE.
No, there's 4. What's the inner one?
The
That
inner one, like external limiting,
external limiting, and what's this one right below the
the
external?
ISOS,
Uh,
or ellipsoid.
interdigitation.
Oh,
So you have 4 layers. I'm sorry, no, you're right. I'm sorry, I'll go backwards. No, you're right. So external membrane, ISOS, and then what's this one here?
that darker one. So,
No, the bright one. There's 4 bright lines.
it's I thought it was RPE and then Brooks.
No, you
That
can't
was
see
wrong.
Brooks. Brooks, you can't see Brooks on these. It's too thin. You can see Brooks sometimes. So you've got your externally membrane, your ISOS, which you said, and then you've got your interdigitation, and then you've got your RP line here. So the RP is kind of this back bright line.
Mhm.
So if you look right here, the back bright line is still
Stays there,
stays there,
Mhm.
and then these guys all go up, and one of them kind of disappears. It's a tricky one. The other ones might be more obvious, but what I'm kind of getting at is that's subretinal.
Okay.
But let me see the other images are better. Let's see, do any of them show more RP underneath it?
This
You're
is
kind of, yeah,
semi, I think, but
vertical.
yes.
It's hard because the RP is not behaving like a single band. It's got all this crap in it. So it's hard to say like, is that, but if you look right there, the RP still goes.
Yeah,
kind of
I can
into
see that.
So
It's kind of tricky for me as well.
It is
This
tricky.
is subretinal looks like. And yeah, that's the right eye and this is the left eye.
So the left eye, so this subretinal deposit of like hyper and kind of.
I guess the other way to look at it would be if you looked in the middle, because it is hard to see. We'll show some later. If you have an RPE detachment, the top of it, you see the RPE all the way across it.
Mhm.
It's pretty bright. It's kind of like looking at a retinal attachment on an ultrasound. It doesn't disappear. So in an RPE detachment, that would be still bright. And it's
Mhm.
kind of turning into just looking more like outer retina.
Mhm.
So that's the other way to look at it. It's tricky.
Although it looks similar, maybe a little bit more out of retinal disruption, in this left eye. The same, kind of the same thing.
Now, the other thing on the vertical cuts I wanted to get you to get is this is the bottom and this is the top. And remember all those spots we saw on the infrared?
Yes.
Are you seeing anything like there?
So are those just, are those like the pseudo?
Yeah, pseudodrusen.
Okay.
So you should see them on the OCT.
Uh-huh, and they are above the RPE.
Yeah, so here, 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 they're not much. I mean, for as much as they showed on the IR,
Mhm.
and if you go back to the,
They're more concentrated outside.
yeah, so here too, this is the right eye. So you got here, 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 and then in the left eye, you've got these guys. So those are the pseudodrusen. And they're not that striking on the OCT. The IR really showed them.
Mhm. I skipped over them entirely.
I think that's it, right?
Okay, so,
I didn't summarize the findings, forgot to do that, but I guess summarizing it, you have the like yellow pigment in both eyes centrally in the macula. And on OC, and you also have those kind of hypofluorescent spots in the you have hyper reflective areas in the macula here. And on autofluorescence, you have some slight hyperfluorescence with hypofluorescence surrounding the center of the macula. And you have those dark spots in the periphery as well. And you see kind of like a dome-shaped area in the center of the macula on the OCT slices with that hyperreflective area, subretinal, and the hyporeflective, like Kim was saying, right above it. I think you can call this like clumping of like maybe like pseudodrusen, you can call them perhaps. And that hyporeflective area above it. And I guess for the differential.
so, this gentleman was older and he was like 80 something.
70, 80.
So I would have adult vitelliform dystrophy as my top if he was younger than Best disease. Other kind of pattern dystrophies in general would be up there. You could think of like, if this was like subretinal fibrosis for like AMD. And then those are probably my top things right now.
Yeah, so yeah, like you said, the main one is the vitelliform. That material is likely like vitelliform material. So genetic causes of that are include the adult onset vitelliform dystrophy, Best disease less likely given his age. I also saw stuff about autosomal recessive Best retinopathy, which is similar to Best disease, but similar, it's the same mutation in the same gene, but it's autosomal recessive, so it's a different mutation, I meant to say. Other causes that can also cause that accumulation of that vitelliform material, that can kind of mimic it, is AMD. If you have like a bunch of like kind of drusenoid, if you have a drusenoid PED, from age-related macular degeneration, that can kind of mimic it as well. The vitelliform exudative macular detachment can look very similar to Best disease, in that you have that dome-shaped kind of, they describe it like a fried egg appearance on the OCT. And you can also have many other kind of things that cause vitelliform, the accumulation of that vitelliform material. And before I go into kind of the differential, I just wanted to talk about vitelliform lesions a little bit. So you have this accumulation of the vitelliform material between the photoreceptor layer and the RPE layer. And it's comprised of melanosomes, lipofuscin, melanoprofuscin, and other outer segment debris. And it located between the RPE and the photoreceptor layer. And so I said this it's characterized by hyperreflectivity on the OCT and hyperautofluorescence on the fundus autofluorescence. And originally I had kind of trouble seeing the hyperautofluorescence. I thought it would be a little brighter.
Yeah, this was not as striking. You expect this just to light up and it didn't. I'm not sure why.
That's what we should make sure of that. Okay. And so kind of the pathogenesis of it is you have impaired phagocytosis by the RPE cells, and that kind of causes that accumulation of that vitelliform material. And one of the hypotheses, you have that kind of pseudodrusen accumulation, that I believe that's a hyperreflective material that you see here in the bottom part of that dome shape, and that accumulates, and that kind of causes this impaired phagocytosis of the RPE material, leading to that vitelliform material accumulating there. And overall, for kind of most of the vitelliform lesions, their vision is relatively good. Like this woman's vision was 20/50 in both eyes, and when you see this, I wouldn't really have expected that, given it's right in the center of her vision. But so generally speaking, vision is relatively decent compared to how significant the impairment looks on the OCT scans. But the risk of severe visual deterioration later on is generally caused by geographic atrophy and macular neovascular lesions. And if you have that, that would require anti-VEGF, and that's kind of uniform across all the causes of vitelliform lesions, it seems. So this lady, in terms of which one she has, I was leaning towards the, I was originally leaning toward the adult onset foveal macular vitelliform dystrophy, since it was bilateral and it's adult onset and kind of describes the findings that we saw in the OCT scan and her vision. Oops, a lot. So, oh, sorry, what am I
Well, I
looking?
guess you could put another category and just put reticular pseudodrusen.
Yeah, I think he has that. You have that?
Degenerative.
You do your thing. I sent you a paper. Do you?
So, I have a question. You were kind of distinguishing that subretinal, or within that subretinal lesion, you were distinguishing
So there's two.
two like findings, those focal areas of hyperreflections. And are you saying?
So I'm saying
like,
this is kind of that pseudodrusen deposit.
right,
material.
which then led to
That's kind of like the
continued
pathophysiology. Yeah, like the accumulation of this vitelliform material. And that's caused by, like, I believe, with what kind of the paper described it as, is this kind of accumulates here and prevents the phagocytization of like the RPE material, that causes that material to accumulate.
That could be.
I mean,
All right, keep going.
I kind of go through some of the causes of vitelliform, although this is unlikely in this lady, but if it was a young patient, it could be considered, you can consider Best disease, like Best vitelliform dystrophy, generally presenting between 3 to 15 years of age. It's autosomal dominant with a mutation in BEST1. The BEST1 gene was codes for bestrophin. I think it's relatively easy to remember because it has the word best everywhere in it. And that gene codes for
Cancel, Code Red, Bayshore Pavilion, third floor,
codes for plasma
Code
membrane.
Red. Bayshore Pavilion,
That
third
codes for
floor.
that works with the ion channel in the RPE cells. Kind of something unique about this is you would expect a normal kind of how to differentiate. One way to differentiate Best disease is you would do an ERG on them, they say, and if it's a normal, you would expect a completely normal ERG, but when you do an EOG electrooculogram, it kind of tests the RPE potential in their light and dark adapted states. And if there's a significantly low ratio, that kind of lets you know that you have a high suspicion for Best disease. I mean, if you also see like large egg yolk looking lesions in both eyes in a relatively young person, that would kind of also lead you there as well. Best disease, you can also see some multifocal vitelliform lesions kind of in the periphery as well as a center as well. And you see that in about 30% of patients. So this is a recessive form of it, autosomal recessive bestrophinopathy. Mutation of the same gene BEST1 and bestrophin. However, they described it as biallelic and recessive. And this kind of differentiates from Best disease in that you have dysfunction in the ERG, you have greater loss of visual acuity, you have irregularity in the RPE, and you may see kind of punctate flex in the periphery, or dispersed punctate flex, but that's not to be confused with the multifocal vitelliform lesions that you may see in Best disease. Adult onset vitelliform macular dystrophy. This is what I suspect this lady has. They usually have It's important to know it's bilateral, smaller foveal center vitelliform lesions. I believe they described it as less than 3 disc diameters. Best disease usually is quite significantly larger. The lesions that you would see in this lady, it was relatively small. I think it was like about a disc diameter. If we could scroll back over here. Yeah, less a disc diameter, maybe a little less. And best would be significantly larger. Oh, and onset 40s to 60s, this lady, her vision loss was chronic, so it's a little hard to tell exactly kind of when it started. It's also autosomal dominant mutation in the PRPH2 mutation. In this, you would have a normal EOG, kind of one way to help differentiate it from Best disease, and it's classified as a pattern dystrophy. Something that can look very similar to Best, this egg yolk shaped material in the center of the macula is on the differential is a vitelliform exudative macular detachment. I believe these tend to be more unilateral. It looks very similar, presents with kind of similar visual outcome. You generally have like not significantly worsening vision with 20/50. And you see that kind of a very similar yellow material and vitelliform material looking like a macular detachment. However, one way to tell the difference is for vitelliform exudative macular detachments, you'd see a lot of cuticular drusen surrounding it. When you compare it to Best disease, you don't really see many of those many drusen around Best disease or pseudodrusen like you saw in this patient. I didn't go into the pseudodrusen. Oh shit.
Yeah, so I thought this was a pseudodrusen one, not a adult.
Okay, I didn't notice the
pseudodrusen? Okay,
but I first.
sorry. So yeah, she got a ton of them on the IR. So yeah, there's, I used to call it, so anyway, just to correct things. Until a couple months ago, I used to call these all pattern dystrophy, but I don't think that's correct. So there's a bunch of things that can cause vitelliform lesions. Let me see if I can get this open. There was a great survey of ophthalmology I sent out to you. Let's see if I can find them. Just quickly, there was a survey of ophthalmology just came out a month or two ago on vitelliform lesions, which was excellent, and it gave all the hold on here survey. There we go. Here, get this back. Gave this. Can you see that? People on the internet. So basically, there was this has vitelliform maculopathy. It talks about the common pathway being the phagocytosis, and then it goes into different causes. And it was the pathogenesis is probably absorption thing. So these are kind of the vitelliforms that you would see with acquired vitelliform. I don't know if they call this a dystrophy, but there's a whole bunch of etiology. So the genetics are these are really small, but the genetics are the ones you were just talking about. Tractional, which I thought was fascinating, because I see about 10% of they said 5 to 6% of epiretinal membranes. 5% or 6% of epiretinal membranes actually do have vitelliforms, and that's true. I used to tell them it was macular degeneration. I'd say, oh, you got your macular degeneration hold you up, but it's actually not. It's just a vitelliform lesion from the epiretinal membrane, and it does, I think, reduce the visual outcome. The interesting paper. And then there's these paraneoplastic syndromes, the adult exudative para. You had one of these, Karina. Remember the multifocal? Yeah, that's kind of a cool case. So you have these multifocal vitelliforms. There's some toxicity. The pentosocin is toxicity is thought to be a vitelliform pathway, and then there's the macular degeneration vitelliforms. And the macular degeneration vitelliforms, I think an older person with pseudodrusen, even if it's just a couple, it's probably not a dystrophy. It's probably because the pattern dystrophies, they tend to present in 40 and 50-year-olds. So if you get a 70, 80-year-old, I think it's the macular degeneration. So anyway,